Welcome to this UCL lunch hour lecture on why brain tumor care needs artificial intelligence. My name is Pashkev Nachev. I'm Professor of Neurology at the UCL Queen's Square Institute of Neurology, where I lead the High-Dimensional Neurology group. My group is focused on the development of novel AI for neurology, neuroscience, and related disciplines. I'm delighted to introduce today's speaker, Dr. James Ruffle. James is a Medical Research Council Fellow at the High-Dimensional Neurology group, and he's also Neuroradiology Fellow at the National Hospital for Neurology and Neurosurgery. His work is concerned with AI models, not just of medical imaging, but also other rich data, such as genetics, with the objective of improving both our understanding of the brain and the quality of clinical care. Before we begin, I should tell you that we will have some time at the end of the lecture for questions, and these can be submitted at any point during the talk by going to Slido, enter that into your internet browser, and entering the event code #braincare. Now, as you listen to James, I would ask you to reflect on 5 ideas that depart from the popular perspective on AI and its role in healthcare. You will see that AI is not a luxury here, but absolutely essential to personalizing treatments. Its primary role is not to make the lives of doctors easier, but to improve the care of individual patients. It's not intended to replace doctors with machines, but to humanize care pathways that are already too mechanical. And it is not a threat to quality or fairness in delivered care, but a critical part of assuring it. Also, it's a technology that shouldn't be offloaded to big technological corporations. It's actually developed within hospitals and universities in joint collaboration with enterprise. These are very abstract ideas, but you'll see how they become very concrete in James's presentation, which is focused specifically on brain tumors. Over to you, James.
Thank you so much, Professor, for that introduction, and thank you so much for joining us for this lunch hour lecture today. Delighted to speak to you over the next 30 to 40 minutes or so about why we think brain tumor care needs AI. And as Parashkev has said, throughout this talk, please just think about any questions you may have, any ideas you may have even, that we can then all discuss as a group at the end about how we better healthcare provision in these patients. So let's give you some stats to begin with on brain tumours, and this is from the Cancer Research UK. There are nearly 13,000 new cases of a brain tumour every single year, but nearly 5,500 patients die of brain tumour every year. Where other cancers have seen striking improvements in survival, in treatment outcomes, in new treatments altogether, such as things like breast cancer, in lung cancer or blood cancer, unfortunately, brain tumours in many ways have been left behind. There are certainly some types of brain tumours where we've seen radical advances in how we treat people, how well they do after the treatments we give. But there are many other times, particularly ones such as a glioblastoma, where the survival remains very dim. So they've been left behind, and we need to think about how we innovate in this space. I'll show you some statistics furthermore from the Brain Tumour Charity, which is another big UK charity fundraising purely for brain tumours. Brain tumours reduce the average life expectancy by 35 years of an individual, that is globally, and 27 years in the UK. Over 1 million people live with a brain tumour in the world, 88,000 of those living with one in the UK. And again, that same statistic is even more amplified, that just 12% of people with a brain tumour live for more than 5 years. So that really is something that we need to do something about. It is not just us who is thinking about this. And in fact, globally, but also nationally, even the political scene, it is something that has been closely prioritised for some time, even as shown in this all-party parliamentary group document here, on brain tumours, now published in February 2023, where they set down key milestones, barriers, aspirations even, for how research and how healthcare can change to innovate in this space. And we're now starting to see on UK Parliament records, things like brain tumour bills passing, going through Parliament, such as here, this one is for glioblastoma, that particular subtype, particularly for survival, where they are trying to open up new methods or lower barriers to get these patients into clinical trials, to give them the best chance, but also to give research the best chance Before we go on to the meat of this talk, talking about brain tumours and AI more specifically, I just want to spend a moment or two going through the strategy that is put forth from the Brain Tumour Charity on things that should change. And there's a lot of text on this slide, but I really want to draw your attention to these areas that are highlighted in red, and just bear them in mind throughout this talk. So here, to have more effective treatments, this remark here that brain tumours feel like the forgotten cancer. Remember, I mentioned many others have seen great advances, but brain tumours regretfully have not. To feel more hope and have less fear, to make choices about what matter to us, to collaborate, to accelerate change, to be diagnosed promptly with the best care for life, to feel connected and powerful, and to be people, not just patients. And these are quite profound and really important strategic items that are enumerated by the Brain Tumour Charity. And just bear those in mind as we go through these slides, and we'll come back to them at the end. So first thing first, what do brain tumours look like? I'm a radiologist for a living, so I sit in a dark room and I look at lots of these pictures as part of my livelihood. These are all pictures from an MRI scanner. So these are the scanners that are powered by magnets, not by radiation. So there's no harm or radiation dose from these type of scanner. It's the one that's slightly tighter than a CT scanner for anyone in the audience who's had one before. And these are 6 different patients. And all of these show a patient regretfully diagnosed or showing a brain tumour, particularly a glioblastoma. The way these are orientated is they're kind of bird's eye views of the brain, if you like. So where my cursor is scrolling, these are all the front of the brain, and these are all the back of the brain. And so here on the sides, these are kind of where the ears would be. This is more towards the top of someone's head, and this is more towards and the main take home to show you here is that these brain tumours can occur anywhere, although there are certain spatial predilections, but they can occur anywhere and they can all look quite different. But nonetheless, the common theme here is that they all have this aggressive, nasty looking appearance, particularly in this diagnostic case, for something that is there that shouldn't be for these. Okay, so that's under a scanner. What do they look like under a microscope, which, as you can imagine, is an important part of the patient pathway here. After they've had that imaging undertaken, either they might have a biopsy of this lesion or they may have it taken out straight away in surgery. And there is similar heterogeneity for how these things can look. So these are all different brain tumours. They're all types of glioma, which is a kind of more of an umbrella term for some of these different tumour subtypes. And hopefully I can convince you, and again, I'm not a histopathologist, but these images look different. So the fact is that there is a heterogeneity for how these images look, how these tumours look macroscopically under a scanner and under a microscope also. If we go even finer, how we now treat brain tumours is that we will test the genetics of them. So rather than just the slide images here, we will then do a whole host of genetic tests to say what these type of tumours are. And this, what's called a Sankey plot, is quite complicated, so but we won't spend too much time on it. Really what I want to draw your attention to is on the far left here, we have these main adult categories of glioma, that common tumour type. So oligodendroglioma here in blue, in green glioblastoma, and in orange astrocytoma here. And then the kind of wavy connections are to all this vast array of genetic testing that can be undertaken to say what type of tumour is it in greater granularity. And importantly, this is what we now use on the global scene for treating and diagnosing brain tumours. So this is a classification document from the World Health Organization that set forth the tests that we should undertake and the interpretation from said tests to make a certain diagnosis. The key take home here that hopefully I can convince you for any who are not geneticists in the audience that this is really complex. It is highly variable. And what I haven't told you about is that moreover, this can vary from one person to another, even more within a person. So they may be diagnosed with one tumour and then this may change. It may evolve over time. So there is an awful lot of complexity here that complex models such as AI that we'll come on to can make more sense of. Let's talk about the patient's journey and how the use of AI technologies could intervene or improve care here. The way it will work is that a patient will present in some way to the healthcare service. They may either go to their GP first, or they may go to the hospital straight away, such as via A&E, with a new set of symptoms, a new set of concerns, and then likewise concerns may be amplified by the healthcare worker seeing said patient. After that point, they will then go for some sort of imaging relatively promptly. This is under a cancer pathway in the UK. So we have things like the 2-week wait protocol. So we try and get these patients in for a scan very, very quickly. As you can imagine, with the NHS under its kind of strain, that sometimes becomes tricky, which we'll come on to later. But nonetheless, this is part of a platform that we operate where we try and get them in the scanner very quickly to have a look, is there something in there? If there is a tumour indeed in there, or what looks to be one, often the decision is then made of whether we need additional information, like whether we should biopsy this lesion, take a small sample. So the neurosurgeon would take a small sample and send it to the pathology teams for further testing, such as that genetics or microscopy I showed on the earlier slide. And after that, when we've got an idea of what this is, then comes the decision making of how do we treat them. It is the common three, as is often in cancer care, of surgery, i.e. can you take the whole thing out or do your best to get as much of it out with the neurosurgeons? Or do you give them radiotherapy or do you give them chemotherapy? And it's often a combination thereof. After that's been done, after we've given our treatments and we've done our very best for these patients, is then this period of post-treatment monitoring. This is often done with further imaging. So after the tumour has been taken out, we keep a watchful eye to see, does it stay out or does something grow back, unfortunately. And sometimes this might even prompt further biopsy testing and sending this back to pathology, or has even the tumour changed over time. And as one might imagine, this can cause an awful lot of anxiety for patients in this kind of watching and waiting. They've already gone through the enormous stress, the life-changing event of being diagnosed and treated with one of these, and now they have to live afterwards with the aftermath of waiting, watching and waiting and hoping. And indeed, patients may not be aware, but this even causes us as clinicians an awful lot of anxiety as well. We go through many of these cases on a weekly basis, and it is tense, it is stressful, watching and waiting and hoping that the best comes for these patients. And unfortunately, sometimes where it comes back, this then, of course, prompts a retreatment. So that was the patient's journey in brain tumour care, and in fact, a lot of cancer care more broadly. Let's take a tangent for 1 second to talk about AI and the terminology, which is really the second part of this talk that will then harmonise. We hear the word AI everywhere now. It is this all-encompassing term that has evolved over time. I was on call on Saturday at Queen Square Hospital, which is the allied hospital to University College London, and I had Radio 2 on in the background as I was reporting my cases, and I think across 4 different panel shows in that day, AI was mentioned in some way or another, whether that was language models, where it was this vision model or whatever. Even the radio this morning was talking about the use of AI in screening mammograms. It is now everywhere. And it was classically referred to this ability of a computer to perform a task that could mimic the ability of the human mind, such as to learn. This definition is relatively old school now, and it came from things like game theory, when individuals were developing things like a computer game, kind of AI bots, so you can play chess against a computer and so on. It's a relatively historical definition, which has now evolved, that often describes something much more broad about modeling complex relationships between things. And this may involve learning from data, but even other processes such as with generation of data or even synthetic data itself. And so things like ChatGPT, these large language models, are all part of this generative AI boom, which can generate you content as well. So it's evolved over time. And there's this kind of hierarchy of terms that is often quite complicated to understand. Which bit are we in? What is this now talking about? Where you have AI, and within that you have machine learning, within that you have deep learning, and then somewhere on the side you have this thing called computer vision. And now, particularly in the last few years, you now have something else on the side called large language models as well. So all these complicated terms get batted around. So what are they? Well, machine learning is this area of computer science where a system develops the ability, or can be taught to develop the ability, to learn with data, but without explicit programming. If I were to ask you rhetorically how many of you use AI in your everyday life, I'm sure that many of you would probably say no. And I'd beg to differ that actually many of you probably do, and you might not even use it, whether that's after a hard day at work and you settle down and you put the television on and you think, what should we watch? And then you're greeted with this recommendation system here saying, oh, I think you would like this. These tools have been baked into things we use in our everyday life, and Netflix is but one example here, where given the things I have watched before, what does it recommend I should watch next? So it's a personalized model recommending. And likewise, given what I've looked at on Twitter, what does it also think that I might enjoy looking at, or even news articles and so on? It is everywhere. What about deep learning? This is an area within machine learning where it has algorithms that use layers and layers of nonlinear processing. This has been likened in some circumstances to that of how the human mind works, how the human brain works, all these different connections to give rise to a complex function that the brain operates with. An example here is a neural network. And so here is one example. So in travel planning. So here I've planned my journey from the Royal London Hospital to University College Hospital. And you plug this into Google and it gives you very personalized, bespoke, time-specific, traffic-specific information that is drawing on complex data more broadly and using various layers and layers of nonlinear processing to say, actually, the quickest way is to take the tube, but it would take you 6 minutes longer if you took a cab otherwise. What about computer vision? This will form a large part of this talk, but this refers to the area of deep learning with anything visual, as one would imagine. And so a key example here would be things like autonomous vehicle development, which maybe some of you in the audience have used, but I'm sure will at some point become more and more common on the global scene, such as here. So that using the information in front of the dashboard, the lanes on the road, the traffic around you, if a pedestrian is crossing, how do you navigate that space safely? And that is what these models are being taught to do. And lastly, but not least, is large language models, which I'm sure many of you used things like ChatGPT. But what better way to describe it than have a model describe it itself? And so a large language model, as it is given in me here verbatim, uses vast text data to generate, understand, and respond to human language based on patterns. They use a huge amount of text to generate you text if you ask it a question. So what is the general approach in AI? The overwhelming approach is that you want to first train a model. What does this mean? Well, you have data of some description and you have a model that you want to learn from. And so iteratively and progressively, you will give this data to the model and the model will try to learn something about that data. What might it learn? It might learn to predict something like what television show should I watch next? Should I move out the way, transfer into a different lane if we're driving a car? It might not even be given a task and it may just be asked to learn representations or broader patterns of the data, let the data do the talking. And this is often done iteratively through a training period where it will try its best over time to learn this data pattern. And after this is done, you then have this validation and testing phase where you have new data that's been entirely unseen that the model has been totally held out from in the training phase, that you now have your trained model, and you then do your hard test of how well will it perform on something it's not seen before. Has it not just overlearned what it had learned in the training phase? Can it generalize out of distribution? And the clincher here, particularly for healthcare and brain tumors and a lot of science, is that data could really be anything, more or less. It could be about the patient. It could be about their imaging, whether that's neuroradiology or imaging more generally, or pathology. It could be about the hospital, the infrastructure of the hospital. It could be about any kind of treatment, or it could even be on time, such as that watchful waiting after a treatment has been given. Why does this matter? Well, it represents an opportunity in healthcare that many people have realized for a long time now, but has become increasingly more apparent, including within the NHS. For those of you who don't work in healthcare in the audience, how healthcare works at a global scene is that we take a group of individuals that have been diagnosed with a specific disease. They've all been diagnosed with a heart attack. They've all been diagnosed with cancer, and so on. It is true across all types of diseases. And by and large, we then compress all of these people into one, regardless of the traits necessarily about them, particular genetic makeup, things that make them, even their, perhaps their choices to some extent. And then we follow a disease-specific algorithm. This is particularly how the NHS works as well. We follow best practice that has been determined by the decades of research that have come before us, but also live experience in the wild, so to speak, in healthcare, of what tends to work best for the population. So we then say, okay, given this diagnosis, a heart attack, a cancer, and so on, it's first often best to give this treatment, then this one, and that one. This is how healthcare works. But the opportunity with AI is that it offers an opportunity to understand data in a much more complex and comprehensive way. So to take vast amounts of information about you, the individual, and to provide something much more bespoke or patient-specific. And so given these factors about the individual, in fact, actually giving them treatment 3 before treatment 1 may be preferable, or giving them treatment 2 with treatment 3 and then treatment 1 may be best, and so on. And as I say, this is an opportunity and a vision that have been echoed across a lot of healthcare now. And this is a key document from 2019, what's called the Topol Review, which came into play when Jeremy Hunt was in fact the Secretary of State for Health, who met Eric Topol, a cardiologist and scientist in the States, who was really big talking on AI, and everyone's sort of like, what's this guy talking about? And in fact, the two of them met and then was born from this document about how AI could shape future digital healthcare in the NHS. It is also very on brand for UCL. For I'm sure many of the staff members who may be listening to this may know about this, but maybe you don't, is that Keir Starmer even visited UCL in the last 2 weeks to set out his new action plan. There were many key professors in the audience, including my chair nonetheless, to speak to members of their team. And so Keir Starmer put forth his plan for AI in boosting growth and living standards and to revolutionise public services. It was given at UCL East only on the 13th of January. It was all over BBC News, if any of you saw it as well. And the key here is this discussion of revolutionising public services. Of course, a big part of this will be the NHS. So in the next 20 minutes or so, we're going to go through this patient's journey that I've gone through at the start. I'm going to give you some real examples that have been developed both within Professor Nachev's group and beyond about the technologies that have been developed that we hope can start to catalyse this domain and indeed inform better decision-making or even better research and hopefully healthcare also for how we can optimise pathways in brain tumour care. So let's talk about that first stage, which is getting them to hospital and often getting them that scan. Until they've been in the MRI scanner, we've got no idea if there is a tumour in there, if it's totally normal, if there's something else altogether. And so actually getting them to that appointment is really important. And as you can imagine in the NHS now, where waiting lists are ever increasing, I don't know how many are waiting for a scan themselves or a GP appointment, it can be tricky, unfortunately, with the healthcare under strain. So there is a key market here to improve that. I know here it was reported in the article in The Guardian, but I'll show you the article in a second. This is from Professor Nachev's group, where they developed an AI algorithm to identify patients that were likely to skip appointments. We call this in healthcare DNA, did not attend. And just as important as that is that, of course, you then also identify those that will engage. And from that, by knowing who will and won't engage, you can then put in place implementations to check in on that patient who's unlikely to attend their appointment. Do you need additional help getting to the hospital? Did you need reminding or so forth? Or if the individual will not attend regardless, in a case where waiting lists are ever increasing, you then have an opportunity to not waste an appointment. You have the next patient scanned early even and benefit them. And so they did this. They built a machine learning model from 22,000 appointment data for MRI scans at University College Hospital, again, the adjoined hospital to UCL. And they produced this fantastic paper, which you should go check out. It's from Amy Nelson, the first author on hospital attendance. And I show you one of these key figures here, which is called a receiver operating characteristic curve. What this shows you is on your y-axis, this true positive rate. What is the rate at which it correctly identifies a patient will or won't attend their MRI scan? And on the x-axis, that false positive, it incorrectly identified that. And so if you had a coin to simply flip, do we think the patient will attend, yes or no, this chance event, then you would see a red diagonal here, this kind of red chance event that it is got no information, it's purely predicting at random. Whereas a model that is performative, that is doing a really good job at identifying patients that will be a no-show or indeed will show, you would see a line that comes up towards this top left corner. And that's exactly what we see here with their paper, that this model has done a fantastic job of identifying a huge number of these patients that will or won't attend. Just as important as predicting if they will or won't attend is why. And so here in another figure is their feature importances. And this is done with what's called Gini importance, which is a metric for feature informativeness. And here they enumerate 8 top important metrics for why a patient may not attend their appointment. And it is things that importantly make clear sense to me as a clinician, I'm sure to many others, or even the audience more broadly. If a patient has been waiting a huge amount of time for their appointment, maybe they've forgotten about it. If they've had lots of appointments before and they've got a good track record of attending them, they're likely to continue attending. Latitude and longitude, if they live really far away from the hospital, maybe it's difficult for them to get in. Maybe there are barriers to get them in. And previous non-attendance, things like that. So, if they previously attended, they're likely to continue to engage. If they previously not attended, unfortunately, they're likely to still not attend. And so whether or not you can then develop interventions around this to maximize healthcare, both for the individuals, but also for the public more generally who are waiting for these scans. So you've got them into the scanner, hopefully one day with the use of these AI tools. And then they've had a scan. So I showed you this earlier on. These are 6 different patients with a glioblastoma. And again, these are the front of the brain, and these are the back of the brain. This is towards the top, this is towards the bottom. It's kind of this bird's eye view. And so individuals like myself, and indeed many others at the Queen Square Institute of Neurology, will be reporting these images, and we'll go through and we'll make a comment about it's in this part of the brain, or this amount of what's called enhancing tumour, this bright white bit that you can see here, is particularly thick in this patient, or it's much less so in this one. Or there's this one comes very close to an area involved in motor processing, as this patient does here. And so we'll kind of write this in prose. We might give some measurements as well. And as you can imagine, there is some subjectivity in that when we're writing these kind of documents. But of course, how it could be with AI is that you could be something much more deterministic in where you're describing and quantifying things. And so here I show you in these bottom panels, this is from what's called a tumor segmentation model we developed in the lab to delineate these tumors across different compartments. So these whether it's edema or whether it's enhancing, this is a bright white bit, or this core, which is often non-enhancing, these different colors. And this model will then segment these tumors so that to the millimeter precision, we can make a remark about them. This, of course, would then assist or provide further amounts of information to the patient, to the clinicians involved in delivering care. When we were doing this, we happened upon a nice circumstance where we found that actually this AI could even delineate bits of the tumor, what's called the enhancing tumor, even when it didn't have the contrast enhanced imaging. What do I mean by that? Well, sometimes with MRI sequences, you have to have contrast to be given. This is done via an injection. Usually the radiographer will put a cannula in your arm. For those, some of you may have even had this before, but not all patients can have this. Sometimes those are in renal failure, sometimes they're allergic, or sometimes it involves just lying in the scanner for a long period of time and it's uncomfortable, noisy. I totally get it. But nonetheless, these are what you would normally see in your post-contrast scan. So we found that the model could still find these tumors even when it hadn't got that information. So I show you some example images here, and I'll put you in the shoes of the radiologist. You are the radiologist for the next 5 minutes. And I show you this example case. So this is a tumor in a patient's frontal lobe. So this is the front of the brain. This is the middle. And there's this nasty lesion here that's quite ill-defined across these different sequences. These are labeled here. But these are not giving contrast. This is not without that injection through the vein. And so we then ask our model, well, can you find me the tumor and can you tell me which bit is enhancing, that bright white bit that we could see on the previous slide here? And what the model said is that for this particular example, there's this really thick, red, scraggy looking enhancing margins. This is this red bit here, based on just these images alone. So if I then show you what was actually the case from this image, this post-contrast sequence that we'd held out from the model, and indeed where a neuroradiologist had spent hours labeling these cases, hopefully I can convince you that this model's done a pretty good job of finding that. I'll show you another case to show you it's hopefully convince you it's not a fluke. So another case, you then play the game of which bit is enhancing. So this tumor here is much more close to the midline. So this is the middle of the brain, which separates the two hemispheres. And you've got these non-contrast sequences. So the question is then, which bit is enhancing? So our model thinks that it's a much more smoother rim of enhancement this time, and there's a much larger central bit that's non-enhancing. There's a large amount of edema as well, this green area here, much more so than the previous case. Maybe that's what you think, maybe you think something different, maybe you disagree. So our model, we then compare that to what was actually there. So this is that post-contrast sequence again, and then that which has been labeled by a neuroradiologist. And I hope I can convince you that this model has done a pretty good job again at finding that enhancing tumor, even when it's been withheld the contrast enhanced imaging. One final example, and then we'll move on. This one is tricky. There's some ill-defined abnormality here. So this is near to the back of the patient's brain. This is kind of roughly where their ears would be, and this is the back of their brain. And there's this ill-defined kind of wedge-like abnormality here across these three different sequences. Is this a tumor? I don't know. It could be. If I was reporting this, I wouldn't know. It could be anything. It could be inflammatory. There could be an infection. It could be all sorts. And so the question is there a tumor in there? Is there an enhancing tumor? So what our model thinks is that there is, amongst what is largely just swelling and edema, again, that's in green, there is a tiny ring-enhancing lesion here, and then that tiny dot of non-enhancing tumor inside it. And sure enough, if we then look at what was true to be the case, this is the post-contrast sequence here. There's this tiny 7mm lesion that has been picked up by this model when it didn't even have that data. And again, we compare that with the neuroradiologists. Beyond that, of course, is that when you've got models that can give you information at this kind of fidelity, i.e. this kind of accuracy, you can do things like quantify the burden of disease. So here on this scatter plot at the bottom right, you have on the x-axis the burden of tumor across a whole cohort of patients, some 1,250 patients. How many millimeters cubed of tumor is there? And then you can do the same where you use this model that's had these contrast enhanced imaging withheld. And the bottom line is, hopefully I can convince you this is a really nice diagonal, that it's done a really great job at still quantifying the burden of disease, even when it's got 25% less information. Okay, fine. So you've delineated the tumor, where the tumor is. Maybe that's not so great. But really what's important is describing it, making remarks about where it is it in important structures, are there important things we need to tell the surgeons who are again going to make a plan about cutting it out and so on. That is really then the next step of radiology's workflow in describing these cases. Unfortunately, as some of you may have even seen in the news, this is from 2018 now, there is a shortfall of staff to do this. There is increasing work lists, and this is not just the case for us as radiologists, it's the case for a lot of healthcare, unfortunately, that people need health, people need healthcare more and more and more, and there is not enough staff, there is not enough appointments apparently to deliver it. And so it's the question of whether or not these models can enable faster decision-making to aid humans, aid healthcare workers in giving the patients the information they need. So that is what we then looked at next with something that's called Vasari features. What these are is a set of quantitative descriptors for where a tumor is, what side of the brain is it in, which lobe is it in, how close is it to important structures like the ventricles, which are these dark bits in the middle, how close is it to the outside of the brain, so there's cortical involvement, such as in this case here. So there's a series of quantitative descriptors. Firstly, we looked at, and this may be too small for your screen, but the text itself does not really matter, so do not worry. We had two neuroradiologists who've been practicing at our hospital for over 15 years. They are experts who have trained for a large part of their lives and then worked afterwards to label this kind of thing. And so we had them go through these cases and label where these tumors were, what was the amount of enhancing lesion, is there just one tumor, is in fact there more of them. And while doing so, we also timed how long it took. So you can see here, for instance, these cases taking 5-6 minutes even. So it's an awful lot of time in terms of when a doctor has, say, got to look at 50 of these cases a day. Just to do this, it takes time. And so that's why there's a finite number of patients that can be seen. And so we then developed a model that could perhaps assist with this, which we can call Vasari Auto, where we had derived these same features as perhaps a way that might decision support the doctors, but could do it in a lightning speed time. So here we show, instead of 5 minutes for a doctor to do it, 2.5 seconds for a model to do it. And what these colors mean, which is much more important than the text itself, is green is where all three have agreed, 2 radiologists and a model. So you are certain that that is what the case within reason. or orange here, where there is a part concordancy, where, say, two radiologists haven't agreed, or in red, where it's disconcordant, where the model has predicted something different than what two radiologists have said. Let's amplify this a little bit further, and I'll show you for one case. Hopefully you can see the text a little bit better. So again, these are with our two radiologists taking 5-6 minutes or so to go through this case and to give me this information about that this patient's got a tumour in the frontal lobe. It's on the right side. When you look bird's eye view, it's kind of on the, it's flipped. How much enhancement is there? There's a lot. What proportion is enhancing? So, for instance, this first radiologist has said that there's between 6% and 30%, up to a third is enhancing. The other radiologist said actually between 1/3 and 2/3 is enhancing. So it's different. There's a conflict there. Whereas the model has said actually no, it is up to a third. So hopefully I can probably convince you that actually across this whole lesion, it is probably a third at maximum that is enhancing. There's a lot here that is not. So actually, what this has shown us is that where there is a discrepancy between two reporters, you then have a third agent that you can sanity check with. For instance, they've all agreed that it is a single lesion. There is not a lesion somewhere else, which is important in, say, planning. Maybe they need to take out 2 lesions or give radiotherapy in the whole brain, for instance. Beyond that is also the efficiency of a system. As I've said, there is a workforce shortage, there is an appointment shortage for patients, and we really do want to do our best for these patients to get them through, but there's only so many hours in the day. So we looked at how long it takes neuroradiologists to look through these cases. And so again, here's the spread across 100 cases, for how long it takes to go through just one case. And then you compare this with the software we've been developing, and then you could even pair this with tumor segmentation as well. And you go down from minutes to about seconds with software as a decision support tool. We thought, okay, that's fine. Well, perhaps we could actually simulate this in real life. We have an important meeting at the hospital, which is called the multidisciplinary team meeting, which is the case for many types of disease, but we also have one for brain tumors as well, where we discuss all brain tumor patients. A lot happens behind the scenes for a patient that they might not realize. And in fact, these meetings have many people on them, from surgeons to oncologists to radiotherapists to histopathologists and radiologists like myself, who will review all these cases as a team and make a plan. So we simulated that perhaps over the next 3 years, if we were to imagine, based on the amount of patients we discuss at these meetings, the neuroradiologist would by hand featureize all these patients, that green line, or if we compared that with a model doing it, or indeed with tumor segmentation as well. Key here is that these axes are logged. So for instance, with a neuroradiologist, this is the dashed line, so this is the cost per centre. You're talking at beyond £35,000 in just staff costs for a radiologist to label this over 3 years alone, which is then more like, I forget what it is now, it's between, there we go, about £2 in power cost, or £8 with the SARI auto with the tumour segmentation as well. There's a huge cost saving that could be had. And even time as well. You take up 600 hours of someone who's trained for 15 years and then practiced for a further 15 years after. They are an expert, taking up 600 hours of their time to do this, that in fact could be somewhat reduced by a decision support tool to something like 9, as is done here. We then got in touch with the British Neuro-Oncology Society, which is a UK-wide society for brain tumour care, and we managed to get a list of every brain tumour centre in the country. And we amplified this simulation to say, well, actually, if we imagined that the neuroradiologists were doing this across the whole country, it would cost more than 1.5 million in NHS funds over 3 years alone, just to do this. Not any other part of the stroke care that they might provide for imaging, or other parts, other diseases and so on. 30,000 hours of staff time that could be spent elsewhere. And then this goes down to mere pounds and fractions of hours purely for power costs for a model to run in the background. So hopefully I can convince you here that using these kind of models as an additional adjunct to kind of increase efficiency, but also do so safely, is going to be key going forward. And in fact, this was even on the radio this morning for screening mammograms, doing precisely this, going from 2 reporters down to 1 with an AI adjunct, that you can still maintain patient-safe care, but do it faster and more efficiently for a wider number. Okay, so they've had their imaging done with radiology. Maybe they then need a biopsy. Showed you this image at the start. And here, these are different types of brain tumours. Well, in fact, it's no different with a computer vision model that could then predict what these types of tumours are, even though these two look very different. In fact, it is both an astrocytoma, or here, this is a glioblastoma. Both of them are quite different. And it goes beyond that, where we've got individuals working in our centre and ED collaboratively externally that are building these kind of what's called vision models, vision transformer specifically models that take a patient's biopsy and pass it to an AI model to try and learn factors about it to predict this is a glioblastoma. That's what GBM stands for here. So just the same as it is for radiology is also the case under the microscope as well. I showed you this slide earlier on about genetics of a brain tumour, and we made the remark about how complex it is and difficult to pick apart these factors between individuals for how we diagnose them. But what if we could? What if we could use models to do that? And indeed, we developed something called graph patient genetic mapping to try and do so, where we came up with this circular plot here where there are individual dots around the outside, 4,023 of them that are individual patients. And then we have lots of connections between them that determine how similar their tumour is to another across all the genetic tests that one does. What this shows you is this radical structure of organised patients by their brain tumour histology and genetics, which is hierarchical. Perhaps me and one other next to me are very similar, but we differ very much so from individuals over there and so on. This is what hierarchical structure does. But importantly, this gives you a richer, more informative phenotyping. So across all these different patients, you then have bespoke, individualized clusters, which say much more about an individual than a diagnostic label could. Key here is that beyond that, it still shows you the diagnosis. So here in green, for instance, between 10 and 3 o'clock, all these patients have glioblastoma, but there is such a richer structure within that than what we currently give them as labels in the real world in the NHS. And beyond that, perhaps one of the things that matters most to patients is survival. And in fact, you can build survival models around that using such information and show you here, this is what's called the hazard ratio for survival. So black has a poorer prognosis and yellow a fairer prognosis. You have this richer structure if you can personalise how we understand genetics in this more robust way. Okay, so you then move on to treatment after you've then diagnosed in those different ways. And I don't have an awful lot of slides to show you on this, but I'm going to show you this one as it's still very much a developing field. There's a fantastic article from Hanny Marcus's group on using segmentation models in pituitary surgery. I won't show you this image for too long. I'm sure many of you are eating your lunch, but pituitary surgery is difficult because the pituitary, which is kind of in the middle of the brain, is surrounded by really important structures. Lots of important vessels that supply the blood to your brain. There are lots of nerves that enable you to do the things that you do and go around and see and smell and so on and move your eyes. And so they have been using AI models to help find these pituitaries better than simply looking through a keyhole surgery. So this is what a surgeon will see. And again, I'm not a surgeon, but it's tricky, like knowing exactly which bit is tumour and which bit is normal tissue that you should stay well clear of. And in fact, they are building models that can help support them as, again, an additional barrier to safety, an additional barrier to giving these patients the best chance to get the whole thing. And so after that is then, after you've given your treatment to patients, then treatment monitoring phase, which I then said about could be done with radiology or again with pathology and that kind of painful watching and waiting period where we're not sure what's going on. And I'll show you one example here. This is from our hospital, actually. This is a patient from 2010, originally, who had a tumour here. This is at the back of the brain here. So they've had a resection. They've had most of it cut out, and there's a lot of kind of edema information going on next to it. And these images might be quite small on your screen, but don't worry, we'll kind of amplify this a bit later. We then keep an eye on them over 2012, 2013. Perhaps it's more or less stable. And then 2014, we then image them again. And in fact, this image at the bottom, there's now some bright white bits, which are enhancement after contrast that wasn't there before. So something is changing in this patient. And again, over 2015, we see this gets more. Of course, with the models we've been describing throughout this talk, you could then make this much more quantitative. So you could then be outlining the contours for these lesions. We're showing in green, this is edema, whereas these red and blue areas are different bits of the tumour that have then increased over time. And again, comes this idea of millimetre-like precision Me looking at this scan, giving labels, measuring things as best I can, will not be as accurate as a model that is doing this in a deterministic way to the level of the millimeter for how much tumour there is. And you can then look at this and actually realise that, oh, actually, there was a response to what treatment was being given between 2012 and 2013. It's then stayed stable for a long time. And then unfortunately, it's progressed. And so it's these kind of models that could then give you much more patient personalised and robust and specific information. Again, one last slide here on outcome prediction, something that matters, perhaps one of the most things to patients surviving, is that there are groups from, this is actually from Tom Booth's group in King's, on predicting glioblastoma survival using imaging. These brains are kind of rotated to the right side. So these are the patient's eyes, for instance, front of the brain, back of the brain. And they've been developing vision models that then can predict if a patient will do really well, such as this patient here, a long time. Or unfortunately, do they not? They unfortunately pass away early, so to speak. So such as patient one here. And you can then build these models that also even highlight areas that are kind of warning spots, as it were. These areas, this is something that the model has paid particular attention to, that it thinks that because of this, the patient will die early. Or actually, given this information, the patient will do quite well. Lastly, as we wrap up, and we'll move on to some questions just in a moment, I just want to show you this slide once again, which is that strategy document from the Brain Tumour Charity about things that they think are vital for how we maximise care in these patients. And again, it was comments about making more effective treatments, feeling more hope and having less fear, and making choices, collaborating to accelerate, to be diagnosed promptly with better care, to feel connected, and to be people. So I hope over the last kind of 20, 30 minutes or so, the examples we've shown you are all in strive of these strategies. And I'm sure this is not just our group, but it is across UCL, it is across our country. In fact, it is global that there are research efforts to try and address these strategies across the entire patient pathway. And so again, thank you so much for listening to this. We're delighted to engage with you for some further questions. And yeah, take it away, Prashka.
Thank you, James. Thank you for that wonderfully illuminating survey of the field. So we're now happy to take some questions for James. While we wait for some to appear in the chat, perhaps we can kick off with the issue of bias that is at the forefront in many people's minds when it comes to the application of these technologies. Could you perhaps give your thoughts on how bias arises in the context of AI, and indeed in the context of models in medicine generally?
Yes, no, it's an excellent question. Thank you, Prashka. So it is this idea of patient equity that we are talking about here for building systems that benefit not just one group, but all groups. What historically was the case in a lot of kind of software development, early vision models and so on, is that it would train these models on very specific groups of individuals, and then you would then expose the model to the wild, and it would only work on very specific groups of individuals. I'll give you a radical example, not in healthcare, but in photography, where a big commercial company was developing photography facial recognition software, and it was only trained on white people. And so this kind of inequity where then it only benefits white people is obviously totally inappropriate, and there is no room for that in healthcare here. And so it is certainly a priority in many research groups, and indeed an avenue of research curves as well, to bake into these models that they are not just simply exposed to one specific cohort, just men over 60 or so on, or just adults even. Perhaps these models should also be trained directly on children as well, that they are then exposed to the whole corpus of what makes an individual, that they can then give performative and accurate predictions across a whole cohort.
Wonderful. And now moving to some questions from the audience. Why do you think the government has only recently become more interested in brain tumor care?
I think that's an excellent question. And I wish I had the final honest answer for you. I've spoken to the Brain Tumour Charity. I've spoken to other chat panels, including at the British Oncology Society, about this. And I think actually a big part of this is amazing hard work from lobbying from these charities. There's been huge investment from other bits of cancer, lung cancer, breast cancer, as I spoke about, and so brain cancer was left behind to some extent, and the charities knew this, and they were excellent at driving this forward, saying what is going on here? This is totally wrong. In fact, people like the Brain Tumour Charity, they have spoken in Parliament. They've spoken to MPs, and it's really helped drive this forward to put it on their radar. So that happened in kind of 2023, that we then got that initial all-parliamentary plan for brain tumours. But beyond that, it actually affected one of their own. So the MP, Tessa Jowell, actually unfortunately developed a brain tumour and then later passed away. And so it was then on the government's door, so to speak, that actually this affects people like you and me. It is around. It is not just a cancer that's rare, that's small, and it has a drastic effect on these people. It has an effect that is much grander, much more significant than many other cancers, to be honest, as well. And so this was right in front of everyone. And so the government realised, Tessa Jowell herself even realised, and then from that, initial initiatives have also been developed, such as the Tessa Jowell project going forward, which is to put even more funding into brain tumours. So I think it's a lot of this amazing kind of increased publicity is credit to the charities, I think.
Well, government has been swayed by all sorts of factors. So their behaviour can be hard to predict. All right, another question. What are I know we've been talking about hospital care, but what are the opportunities for AI in social care in helping people recovering from brain tumours? What are your thoughts on that question?
I think that is super interesting. And it's a place that, to my knowledge, is totally untapped, so to speak, in research. I'm not aware of people doing this, but why shouldn't they be? In fact, it's such a good question. I wish I'd included something on it on the talk, because after, as in fact was a big part of this talk, they follow a relatively regimental treatment regime. You give them surgery, then chemotherapy, radiotherapy, and so on. They have imaging, blah, blah, blah. But actually what differs radically across individuals is their social life afterwards. And this is precisely where these kind of models could take that vast amount of information. What is their home setup? What is their ability to get to the hospital for their appointments? Do they have someone looking after them at home? Can they feed and drink? Can they wash themselves? And so on. So this vast amount of information that would be exhaustive for, social workers, of course, do this for a living, but it's difficult. They're very, very busy. And they do it to a greater or lesser extent. So in fact, where models could then come in is to help optimize this, whether that's flagging a patient that needs more support, whether it's flagging one that's in fact doing really well. It's a super question from the audience, and I hope there are other researchers out there that are already looking at this. Certainly, otherwise we should be.
Yeah. Another question: how does using AI for radiologists speed up decision making if radiologists still need to be involved and review scans?
Yeah, I think that's a really good question as well. I think a big part of that is sanity checking. So I've shown you a lot of images that are quote unquote black and white. They are literally black and white, and the perception is imaging that things are black and white. We can clearly see it's a tumor. We can clearly see it's a stroke and so on. But the reality is that quite often that's not true. Quite often the patient has something that we don't yet know. Or there might be a discrepancy if one person thinks it's one thing, one person thinks it's, multiple sclerosis, and someone else might think that this is another inflammatory disorder or so on, or one type of tumor versus another. And so this kind of discrepancy can then cause needs additional discussion, of course, which is vital, but it can, of course, encumber, therefore, delays in patient care as well, whilst we try and figure out what is really going on. And so really these tools might reduce that barrier, that we can do things quicker, we can give you more bespoke, personalised information. And of course, beyond that, that initial diagnostic stage, I also spoke about follow-up, where we keep an eye on them longer term. At the moment, we kind of look at these patients under the scanner, and we say, okay, broadly the tumor is stable, broadly it's got smaller, broadly it's got a bit bigger. Whereas actually these models, that they can give you that level of millimeter precision, there is so much more confidence that actually we know the treatment's working, or we know it's not, and so you can intervene earlier. So really, I think those are the key areas.
Yeah. And this naturally leads to the next question, which is the question of responsibility, of accountability, which often is raised by people. So perhaps tell us your thoughts on how that is handled by these technologies.
Yes. Broadly, the way it's handled is the responsibility lies with the doctors. So these models go through all sorts of regulatory approval. They go through lots of rigorous testing. There are very good things about this, which are, of course, essential, that you test a system, make sure it's very, very safe. There are also some negatives about them as well, in that pieces of software that we can see in front of us make a real difference to patients may take 5, 10, even longer years to bring them forward. And so, as I spoke about at the start, where these patients, only 11% survive more than 5 years, it's too slow. And so there's a lot of regulation in place to do this. But in terms of responsibility, it does very much lie with the treating healthcare workers. And so should it, I think, as well. I think there was a famous quote from an imaging conference many years ago about AI replacing radiologists. And in fact, the same thing is now going through with pathologists as well, that it's very obvious that doctors will be replaced by AI software. And indeed, that is an element of fear held perhaps by the public, perhaps within the department as well. But I think it shouldn't be. I think when the stethoscope was invented, they said that would replace doctors. The same was true for the thermometer as well. Now that language models are here, everyone's panicking that everyone will be out of a job. And in fact, actually, this will enhance how we do anything, whether that's to provide care or whether it's work in a different sector.
Yeah, these are just instruments, and the responsibilities of the agent wielding.
Agreed.
Moving on to a rather technical question. You talked about 2 specialists and 1 model. Well, how about multiple models? I suppose this is about ensembling. So you can say a word about that.
Yes, that is a really good question. And it's nice to get a really technical one as well. So we didn't do this in our research. We probably will going forward, but it is a huge part of using these AI models more generally. For the audience who aren't familiar with this technique, often it's quite commonplace in building these models that you might give multiple models a go. So if we take as an example, in fact, we come back to imaging, for instance, if we had 5 radiologists look at a patient's scan, you then may take a majority vote of all 5 of them for overall what we think this diagnosis is. And of course, that's a big part of healthcare as well. When we discuss these patients at our multidisciplinary team meeting, we take a majority, a kind of group discussion of what we think it is, what's the best thing for the patient. And that's exactly the same as what a lot of software data engineers also do with AI technologies, where they say, rather than just build 1 model, we'll build lots of them. And afterwards, we'll run these models together, and actually 4 or 5 think that this is the best thing, or 3 or 5 think this, and so on. So that is what the question is referring to, and it's very commonplace, and it adds an additional kind of level of confidence. It often adds an additional level of performance as well, that many people do use.
Indeed, and final question from a GP, Natasha Minas. So we have a 2-4-week rule for referral for brain tumors, but are you aware of any AI tools to speed up referrals for a brain scan?
That's an excellent question. Triaging systems. There are some papers out there, actually. There's 2 parts to that. One of which is, firstly, at getting to the individual who decides, is it an appropriate referral? So I appreciate GPs do a tremendous job just getting their patients into the hospital kind of thing. And they see these patients out in primary care. To get them in is very difficult sometimes. So firstly is that. So how do you triage that referral letter? So someone reviews that and decides, yes, they need a scan. Actually, they need an appointment straight away or whatever. And the second of which is then, once you've decided to say they need a scan, what type of scan do they need? Do they give them, do they scan their whole brain? Do they scan their whole body? And so on. And in fact, there is research on both of those bits, which often relies on large language models, which I touched on at the start, but we didn't show much on, that utilize the information that, say, you as a GP have written about your individual, your patient and what you're worried about for them, that then can allocate them into specific pools. And I suspect if that's not already in some parts of research and some parts of healthcare, it's definitely in some parts of research, it certainly will be going forward, because certainly we want to reduce your barriers to get patients the imaging and appointments they need.
Well, of course, it's always going to be difficult to do something as challenging as triage in an automated way. Good. And that brings us to the end of the questions and indeed the end of the lunch hour. So thank you very much, James, for your wonderful lecture. And it just remains for me to say that the next lunch hour lecture is on the 11th of February on the topic of cancel culture in queer and trans online world. So please do join us then. Thank you, everybody. Thank you very much, and goodbye.